Today we are going to talk about application of the nursing process for your patients that have a psychiatric or mental health disorder. To start, we always assess our patients. Our assessment when a patient's first admitted to an inpatient facility is going to be much more thorough than our shift-to-shift assessments. This interview initially is going to be very important for a lot of things. First, our initial patient interview aims to obtain facts on what's going on with the patient, clarify any of the patient's perceptions, validate our own observations, interpret meaning of what's going on, and compare information. We're going to get a lot of our information from the patient, but we may also get information from interviewing family and friends and looking at documentation from prior stays and treatments. This initial interview is very important for us to establish rapport and trust with our patients. This is best going to be done if we focus on being patient-centered, provide our patient with adequate education, and be flexible in our interview. If we observe what's going on with our patients and use our judgment to center our interview around the patient's needs, we're going to be way more effective in getting the information that we need from the patient, as well as establishing that rapport and trust. This initial patient interview is also going to be very helpful in understanding what's most important to the patient. So we always start off the interview with asking the patient why they feel that they need treatment or why they may be hospitalized. Not only does this give us an understanding of what's important to the patient, but it also lets us know if they have good insight to what's going on with their symptoms and their need for treatment. In addition, we also do a biological or a physical assessment. We're looking at different things like thyroid function, history of diabetes, weight gain or weight loss, poor temperature regulation, any cardiac arrhythmias. We're going to assess their vital signs, neurologic status, and ability for self-care. We can do this through our physical assessment as well as looking at their labs and other diagnostic results. We're also going to do a thorough assessment of the different medications that they take, and this can include both prescription medications as well as herbal medications. We would also want to know if they have any substance or drug use and why they use those substances, how often, if they're effective, and if the patient has any side effects from any of it. Psychologically, we're going to not only assess the response to their illness, like I talked about earlier, but we're going to do a mental status exam, which we'll actually talk about on the next slide. We're going to assess their behavior as well as their self-concept. The self-concept is looking at their body image, their self-esteem, their self-identity, and whether or not they feel that they can get better. Because if our patients have a strong belief that they can improve and get better, their outcomes to treatment are going to be much more favorable. We're also going to assess their coping skills and triggers. Triggers are anything that may initiate psychological distress, whereas a coping skill is an action that we engage in to try and adapt to a situation and reduce stress. Coping skills can be maladaptive or healthy, so we would want to assess that for our patients, as well as whether or not the coping skill is accessible and reasonable to what's going on. We're also going to assess for suicidal and homicidal ideation, which we'll talk about in a little bit as well. And we're going to look at their social systems. This includes looking at their family relationships and their friend relationships and whether or not their relationships are healthy. We're going to do a spiritual assessment, and we're going to look for any religious needs that the patient has while they're in the hospital. This also gives us the opportunity to determine if the patient has any religious delusions or if they're religiously preoccupied, or if any religious practices really are just a true good coping skill for that patient. We're going to assess their occupational status, any economical issues, any legal issues that may be going on with the patient, and the patient's perceived quality of life. From a shift-to-shift basis, we're also going to assess things like their vital signs, their pain, their sleep, any physical needs as needed. But the main important shift-to-shift assessment is going to be that mental status exam. And like I said, we're also going to assess this upon admission. Our mental status exam looks at a wide variety of things, starting with our own observations of the patient. Things that we can get from observing our patient is understanding of their appearance. Is their appearance appropriate to the situation? Is it disheveled? Is it bizarre? Are they wearing multiple layers of clothing even though it's warm outside? We'll be able to assess their speech, and we'll be able to know if their speech is normal, or if they have hyperverbal speech, or if they have pressured speech, or if their speech is tangential or repetitive. We're looking at things like eye contact and motor activity. Motor activity is going to be especially important when our patients are taking psychotropic medications, because a lot of the medications can affect their motor ability. Then we're going to look at their mood and their affect. Mood and affect can be a little confusing for some people because a lot of times they're used interchangeably, but mood is actually the emotions that you're feeling. So you can be feeling euphemic, which is kind of like a normal mood. You can be feeling anxious, depressed, angry, euphoric, or irritable. Whereas affect is the range to which you're able to show that emotion. So a full affect would be showing your emotion to what you're feeling. A constricted affect might be a little bit less than what you're actually feeling. A flat affect is where you're showing no emotion at all. And a labile affect is where your emotions or your mood are kind of all over the place. Then we look at cognition, or the thought process. During cognition, we're looking at their orientation, any memory impairment, their ability to focus and be attentive. We're looking at their specific thoughts, seeing if they have any abnormal thoughts, which we'll get into more when we talk about specific disorders. We're also looking for thoughts of suicide or homicide ideation. We're looking for any indications of delusions. So delusions are fixed thoughts that are outside of reality. And there's a lot of different categories of delusions. So you can have grandiose delusions, where the individual has an elevated perception of their self-importance or self-ability. And so a lot of times these individuals either feel that they're a celebrity, or that they're of genius status, or that they've done or completed things that they haven't actually done. They may also have delusions that they're connected to someone famous. You can have paranoid delusions, where the individual is fearful that someone's out to get them or something bad's going to happen. You can have religious delusions, where the individual either feels that they are a religious figure, or they feel that a religious figure or deity is either controlling to them or speaking to them in a way that is outside of their normal religious or cultural beliefs. You can also have aromatic delusions, where you feel that you're in a relationship with somebody that you're not actually connected to. We're also going to assess at this time if our patient has any hallucinations. So hallucinations are when they're experiencing their senses beyond what's actually there. So an auditory hallucination is when they're going to hear voices or hear things that aren't actually there. You can also have command auditory hallucinations, and that's when the voices tell the individual to do something. You can have visual hallucinations, where they see something that's not there. You can have tactile hallucinations, where they feel something like bugs crawling on them, or pins or needles, or it can be sexual stimulation that they feel without actually doing anything. You can have olfactory delusions, where they smell something that's not there, or gustatory hallucinations, where they taste something without eating it. We're also going to look at their behavior. Is their behavior cooperative? Are they doing what they need to do? Is their behavior guarded, which is when they're a little bit hesitant to share what's going on with them? They're a little bit more reserved into themselves. Is their behavior hyperactive or agitated? Are they hyperverbal or hypervigilant? So hypervigilant is when they have an overwhelming feeling that something bad's going to happen, so they're hyper attentive to their environment. Are they having bizarre behavior, withdrawn behavior? We're going to assess all of that. We're also going to assess their insight and judgment. Based on the actual facility's mental status exam forms, you may also assess other things like their ability to count to 100 using every 5 numbers, or their ability to trace certain objects. And this gives us a lot of information on their emotional as well as their psychological symptoms. For our suicide and homicide assessments, we really want to make sure that we're being very direct. We do know that past attempts indicate likelihood and means of current attempts. So if your patient has a history of suicidal or homicidal behaviors, it's important that we assess that as well. But first and foremost, when we're doing a suicide or homicide attempt, we want to ask straight out, do you have thoughts of wanting to kill yourself, or do you have thoughts of wanting to kill someone else? A lot of people find this question very uncomfortable. So they may say things like, do you have thoughts of wanting to harm yourself? The reason why we want to be more direct and specifically say, do you have thoughts of wanting to kill yourself, is because most people that have suicidal thoughts and behaviors don't see suicide as harming themselves, but rather as a way to end the pain. So they may say no when you ask if they have thoughts of wanting to harm themselves, but they may still have suicidal ideation. If they do have suicidal ideation, you then want to know if they have a plan. If they do have a plan, do they have the means to carry out that plan? If they have the means to carry out that plan, you want to know if there's anything that is a protective factor. So, is there anything that could happen or anything that they need that would prevent them from acting on it? We want to know why they want to kill themselves and if there's anything we can do in that way. And by doing this assessment, it can really help us to both understand how to protect that patient, but also how to help them. As far as homicide assessments go, we would want to ask a lot of the same questions, and this would be really helpful in ensuring that we can protect others as well. Um, if we have reason to believe that a patient does have true homicidal ideation and they are a threat to harming somebody else, we can notify that individual under the duty to warn. After we've done our thorough assessment, we move on to our diagnosis. In nursing, we always have our diagnosis follow the format of nursing diagnosis, related to, which would often be the medical diagnosis, and then as evidenced by, where we would list the different symptoms that support that nursing diagnosis. When we talk about nursing diagnoses, it's important that we know how to prioritize it. Safety is always going to be one of your top priorities. So things like suicidal behaviors or suicidal ideation is always going to take priority over something like um, ineffective coping skills or anxiety. Um, Next, anything that could harm others is going to be a priority diagnosis. Anything that may interfere with their ability to breathe or airway and things like that would then take priority. So it's important to know how to prioritize different nursing diagnoses. Then we look at our plan. When we're planning our goals or our care plan for our patients, we use what's called SMART goals. SMART goals are specific, they're measurable, they're attainable, they're relevant, and they're time bound. So if our goals have all of these different factors to it, it helps us to measure them and determine the outcomes and whether or not that's effective when we look at the evaluation. So a specific goal is something that's kind of like it says, it's specific. We know exactly what that goal is. Measurable means that we can measure it. So we would put it on a scale or a number of times, things like that. Attainable means that the patient is able to actually complete it. Relevant means that the goal fits the situation. There may be good goals that might really be beneficial for that patient, but if it doesn't relate to why they're there and their need for treatment, then it might not be a good goal. And then lastly, we want it to be time bound, meaning we want to have an end date that we can evaluate this goal and see if it's been met. Then we move on to our interventions. Interventions in psychiatric nursing are much more creative and flexible than what you would see in a medical setting. And this is because there's a lot of contributing factors to psychiatric disorders, and there's a lot of different ways that we can treat that. Intervention should always be patient-centered, evidence-based, and appropriate to the situation. One type of interventions that we can do are biological interventions, and these are things like helping the patient with self-care, their hygiene, their ADLs. It can be implementing things like activity or exercise. It can be implementing different things to improve their sleep, teaching them sleep hygiene techniques. It can be modifying their nutrition, helping them with relaxation through deep breathing techniques, muscle relaxation, yoga, things like that. It can be hydration or thermoregulation. It can be treating their pain. It's also treating them with medications and assessing their side effects. When we use a medication for the treatment of a psychiatric disorder, we call it a psychotropic medication. Psychological interventions that we can do is help to change their thoughts, or that's cognitive interventions. We can counsel them through therapy. We can help them with conflict resolution or cultural brokering. We can use bibliotherapy. So, bibliotherapy is when we provide them with a text, whether it be a journal article or a book, and we have them write down their thoughts about that book. And it can either be educational or it can be to help them gain different perspectives or relatability to what they're going through. We can do reminiscence therapy, which is often used in the older adult population with cognitive disorders. And reminiscence therapy is looking back and reflecting on one's past. We can engage in behavior therapy, which teaches them new and effective ways to behave. We can intervene through psychoeducation, which is educating the patient on all matters related to their psyche. We can also do other types of health teaching and spiritual interventions, and all of those would fit under the psychological realm of interventions. Then we have our social interventions. We've talked in the past about milieu therapy and how a huge aspect of milieu therapy is social monitoring and improving the social environment for our patients. We can help to treat them by helping them develop improved social behaviors, by monitoring their safety, helping them with coordinating their care. Again, the conflict resolution can fit under a social intervention as well. And then we can also help improve their community interactions and access to resources. Then we move on to our evaluation. When we evaluate our patients, we're looking at different things. One, have their outcomes been met? Also, has the interventions that we've done been of benefit to that patient? Is the patient satisfied with their outcomes? Is the intervention specific and can we apply it to other individuals that are going through the same thing? And is it cost effective? So that's a brief overview of the nursing process as it relates to psychiatric nursing. So now we're going to move on to the psychopharmacology. And like I said, this is a biological intervention for our patients, and it's based on treating them with medications. There are different phases of drug treatment. The first phase is the initiation phase, and this is based on our assessment. The patient is started on a medication that we believe is best going to match their symptoms. The test dose is the lowest dose possible, and then as we observe the patient on the medication, we can increase the strength and frequency. This test dose allows us to measure for any adverse reactions to the medication and as well as any side effects. Our main nursing goal during this initiation phase is to provide medication education. The next phase is the stabilization phase, and this is when the medication is adjusted and titrated either upward or downward so that the patient reaches the maximum amount of improvement in symptoms with minimal side effects from the medication. Our main nursing priority at this time is to monitor for side effects and make sure that the patient is taking the medication effectively. During this time, we may augment the medication, meaning we add another medication to help improve the effectiveness of the medication. So for example, if someone has severe depression, they may be prescribed an antidepressant. We may also prescribe them with a mood stabilizer to help that antidepressant be more effective. The next phase is the maintenance phase. And during the maintenance phase, we have reached the best dose for that patient to maximize their effectiveness while reducing side effects. And so our main nursing goal at the maintenance phase is to help that patient stay medication compliant. We'll learn about how medication compliance can be very difficult with a lot of different psychiatric disorders. So our main nursing goal at this time is finding ways to make sure that the patient has access to their medications and that they're taking it as prescribed. And in this, we are hopefully preventing relapse. The last phase is the discontinuation phase, and this is when we take the patient off a medication, either because we want to try them on a different medication or because their symptoms have improved and we want to see if they have completely resolved and if the patient can continue their life outside of medication treatment. Because a lot of psychotropic medications have withdrawal symptoms, we slowly taper the medication down. The phases of drug treatment is a very long and lengthy process, and it really does contribute to long hospital stays in the psychiatric facilities. So the first type of medication that we're going to talk about is antipsychotics. Antipsychotics are used to treat schizophrenia and psychosis, as well as potentially bipolar mania, Alzheimer's-related psychosis, dementia-related psychosis, drug-related psychosis, and postpartum psychosis. There are two different types of antipsychotics, with the first type being first generation or typical neuroleptic medications. First generation antipsychotics only treat the positive symptoms of schizophrenia or the symptoms of psychosis, hallucinations, and delusions. The main way that these medications work is by blocking dopamine receptors in the mesolimbic area to suppress psychosis. Examples of this are Haldol, which is probably the most common first-generation medication that you'll see, and Thorazine. While we often don't use Thorazine, it can be used sometimes in patients that are often aggressive when they're psychotic and haven't responded to other types of medications. One major downfall to taking a first-generation antipsychotic is that it has many severe side effects. One of these side effects are your extrapyramidal symptoms. And these extrapyramidal symptoms, while may be temporary, can become permanent if not treated properly. They are often very, very, very uncomfortable for our patients. The different ones are akathisia, which is a type of restlessness, and it can be treated with propranolol, Benadryl, or Cogentin. And then we have dystonia, which is muscle stiffness, primarily in the neck muscles. So it can cause their neck to become stiff and stuck either to the side, looking down or looking up. And that can also be treated with Benadryl or Cogentin. Then we have pseudo-Parkinsonism, which is the drooling, shuffling gait, and masked facial expressions that we sometimes see with Parkinson's disorder. We also see tardive dyskinesia, which is a later symptom of EPS, and this is involuntary facial movements, lip smacking, and tongue protrusion. And then we have neuroleptic malignancy syndrome, which is actually a medical emergency, and it's a little bit different than your EPS symptoms, but it's still treated the same with that Benadryl or Cogentin. NMS starts off with muscle rigidity, typically in the jaws, and it can also include tongue swelling. And then what happens is that as the muscles contract and they become rigid, the patient is unable to physically relax their muscles. We know from anatomy and physiology that when our muscles are contracted, it burns energy, and energy is converted into heat. So with the muscle rigidity, the patient's body temperature starts to increase. The body then starts to implement measures to try and cool the body temperature. So that's things like sweating, shaking. But because the muscle rigidity persists, the patient ends up developing hyperthermia. They can go into a coma, have seizures, and they can actually die from NMS. So it's super, super important that we monitor our patients that are taking antipsychotics for NMS. As I mentioned, this is often treated with Cogentin or Benadryl and other types of antihistamines. So if we provide the patient with this medication early, then it's really effective. And this slide is going to show some of those EPS symptoms. So akathisia, the person's moving their feet in and out, kind of shaking their foot. The dystonia, like I said, is that muscle rigidity where their neck kind of gets stuck in different positions. And then the tardive dyskinesia is the abnormal facial movements, the protruding tongue, and the lip smacking. Second generation antipsychotics, or atypical neuroleptics, are newer medications, and they're much more effective in treating psychosis and schizophrenia because they treat both the positive and negative symptoms. They also tend to have less side effects. However, the side effects are still very severe, and they're much greater than what we would typically see in non-psychopharmacological medications. The side effects that we typically see with a second-generation antipsychotics are weight gain, which can lead to type 2 diabetes. So sometimes we'll put the patient on an anti-diabetic medication if they are taking a second-generation antipsychotic. Dyslipidemia, cardiac arrhythmias, seizure, hypotension, sedation, as well as a lot of those EPS symptoms as well. One specific medication that fits within our second generations is called clozaril. Clozaril has major risk of agranulocytosis. So when our patients are taking clozaril, we're going to do a CBC every so often to measure their blood counts and make sure that they're not developing that agranulocytosis. Other examples of our second generation antipsychotics are Seroquel and Risperdal. Considerations when providing a patient with an antipsychotic is that our goals of therapy is to suppress an acute episode of psychosis, to prevent acute exacerbations, and to maintain the highest possible level of functioning with the lowest side effects. Drug selection is selected based on the effectiveness of the medication, how well that patient tolerates it, and the cost. Dosing is highly individualized. We do prefer oral medications for these patients, but a lot of the antipsychotics can also be given in IM form, and that can be either as an immediate acting medication or a long acting injectable. So because antipsychotics have such severe side effects, a lot of patients are non-compliant with taking them. Patients with psychosis or schizophrenia may also hear voices that tell them not to take the medications, or if they're having paranoid delusions, they may feel that that medication might be poison. So medication compliance is very difficult to achieve in someone that needs to take an antipsychotic. These long-term injectables or long-acting injections give the same medications, but it has an altered half-life. So the medication stays in the person's body a little bit longer, and it can eliminate the need for the patient to take a medication every day. If a patient is receiving a long-term injectable, they typically have to go to the doctors every 2 to 4 weeks to get their medication. We also want to make sure that we're monitoring for those side effects or early symptoms of NMS, and we want to do any lab monitoring for these patients and the medication levels to make sure that they're at a therapeutic level. Next, we have our mood stabilizers. Our mood stabilizers are used to treat bipolar disorder, seizure disorders, and any other mood disorders that are not otherwise specified. Lithium is our golden therapy for treatment of bipolar disorder. It's typically effective in about 2/3 of individuals, and it is technically a salt. So it does interfere with our ability to process salt in our body. So if our patient is taking lithium, we want to make sure that we are monitoring their sodium levels as well as their water intake and their lithium level. Lithium has a very narrow therapeutic index, and it can quickly lead to what's called lithium toxicity. So our normal lithium levels are between 1.2 and 1.5, or I'm sorry, 0.8 to 1.4, and then anything above 1.5 can become toxic. So when we look at lithium toxicity, like I said, we want to see it be lower than 1.5. If the patient develops a lithium level of 1.5, they start to develop polyuria, tremors, nausea and vomiting, and a metallic taste in their mouth. Moderate lithium toxicity is between 1.5 and 2.5. At this point, they're developing blurred vision, tremors, they may develop seizures, they can go into a coma, and we may see EKG changes. Severe lithium toxicity is a lithium level greater than 2.5, and at this point, the patient has often experienced renal tubular necrosis, oliguria, and often death. So again, just like NMS, lithium toxicity is a very serious medical emergency, and we want to make sure that we're treating the patient properly, monitoring those blood levels, monitoring that water and salt intake. If a patient does not respond to lithium, we can put them on an anticonvulsant. When we use an anticonvulsant for treatment of bipolar disorder, we call it a mood stabilizer. The different medications that we can use are Depakote. So Depakote is another one that has a more narrow therapeutic index, so we often have to do lab draws to make sure it's a therapeutic range. We have Lamictal, which is associated with Stevens-Johnson syndrome. And Stevens-Johnson syndrome is a breakdown of your connective tissue. So it starts off with a rash and you start to have fever-like symptoms, and then your connective tissue starts to break down. The individual skin can come off, their eyes can change colors. So that's a very serious medical emergency as well. And then we have Tegretol. And the main purpose of these anticonvulsants is to reduce ion channel activity, to reduce the firing of action potentials, and in that it can help stabilize the mood. Anticonvulsant medications can inactivate oral contraceptives, so it's really important that we educate our patients that are taking birth control to maybe birth control pills to look at other options of birth control, because these anticonvulsants can inactivate those medications. Side effects of anticonvulsants also often lead to dizziness, drowsiness, tremors, visual disturbances, nausea and vomiting, weight gain or weight loss, hair loss, liver dysfunction, and jaundice. Again, we really want to monitor for that Stevens-Johnson syndrome. We can also find agranulocytosis and aplastic anemia can result from anticonvulsants, so we may need to do the complete blood count measuring frequently as well. And this is an example of that Stevens-Johnson syndrome. Then we have our antidepressants. Antidepressants are the first-line therapy for depression, anxiety, and obsessive compulsive disorder. There are different types of antidepressants, with one being tricyclic antidepressants. So when we look at depression, it's often developed from dysfunction in 3 different neurotransmitters: serotonin, norepinephrine, and dopamine. Your tricyclic antidepressants aim to improve the neurotransmitter status of all 3 of those neurotransmitters. Because it's working on all 3 neurotransmitters, it does tend to have more side effects than a lot of the other antidepressants. So we don't necessarily use them as often, but examples of this would be Elavil, Pamelor, and Sinequan. The most dangerous side effects of tricyclic antidepressants is cardiac toxicity. We also see a lot of anticholinergic effects, so the patient may develop sedation, hypotension, dry eyes, and different symptoms from that. Like I said, this is not typically our first-line therapy because we usually start off with our SSRIs, or selective serotonin reuptake inhibitors. And that's because SSRIs mainly work on the neurotransmitter serotonin. Since it's only working on the one neurotransmitter, we tend to see much less side effects. We also find that they tend to be very effective in treating anxiety and depression, and that's because serotonin is the main neurotransmitter involved in the development of those symptoms, even though dopamine and norepinephrine also contribute. The main side effects that we see with SSRIs is sexual dysfunction, nausea, headaches, CNS stimulation like agitation, anxiety, and insomnia, weight gain, and they can also develop serotonin syndrome, which we'll talk about in a little bit. Examples of SSRIs are Prozac and Zoloft. Then we have our SNRIs. SNRIs are serotonin and norepinephrine reuptake inhibitors, and since they do work on the 2 neurotransmitters, they do typically have a little bit more side effects than our SSRIs, but they're still typically very effective and have very minimal side effects compared to your tricyclics or your MAOIs, which we'll talk about in a bit. Examples of your SNRIs are going to be Effexor and Cymbalta. Then we have our atypical antidepressants. The main one that we see here is Wellbutrin, and Wellbutrin aims to block your dopamine. It is used for major depressive disorder as well as seasonal depressive disorder. It's generally well tolerated, and it can also help with quitting smoking. Then we have our MAOIs. So our MAOIs is the last choice for antidepressants because it has a very high food and drug interactions. It interacts with tyramine, which is in a lot of foods like your aged meats, your aged cheeses, fermented fruits, legumes, certain carbs, alcohol. And what happens is when a patient's taken an MAOI and they eat something that contains tyramine, they can develop hypertensive crisis. That hypertensive crisis can lead to things like stroke and death. So it's really something that requires a very strict diet and very strict monitoring. And because of that, we typically don't use monoamine oxidase inhibitors very often. So some basic considerations for our antidepressants. One main thing that I do want to say is it can take quite a bit of time for an antidepressant to start working. While we may see initial responses within 1 to 3 weeks, we typically don't see maximum therapeutic response to an antidepressant until closer to 12 weeks. During the first 2 to 4 weeks, the patient starts to develop improvement in their physical symptoms of depression before they start to develop improvement in their emotional symptoms of depression. Because of this, we find that our patients are high risk for suicidal behaviors 2 to 4 weeks after starting an antidepressant. So it's going to be really important that we monitor our patients that are taking antidepressants for suicidal behaviors. Um, Antidepressants are also another medication that can cause withdrawal symptoms. So we would typically taper the patient off the medication slowly if they don't respond well to that medication. This can be a very frustrating process for people that have severe depression if they don't respond well to the first couple of medications, because we typically wait that 3 months to make sure it's working. If it doesn't work, we take a few weeks to taper them off and then start them on a medication. So it can take some patients years to find a patient that or find a medication that's effective in treating their treating their depression. Um, because of this, they have developed something called PG3 or PG4 testing. I'm not sure which one it is, but this is where they look at your genes to determine which medications you'd most likely respond to. There is controversial studies on whether or not it's effective. So a lot of insurance companies don't quite provide or cover this testing, but it is something that we may see used more in the future. Another consideration is that we want to monitor for serotonin syndrome. Because all of these medications aim to improve serotonin in the body, we want to make sure that we're monitoring for overdose of serotonin. And this is typically more common when our patients are taking other things that may increase serotonin in the body that's not considered a medication. And so they may not realize that they can act together. And the main thing that we see with that is St. John's wort. Serotonin syndrome is symbolized by mental changes, autonomic instability, neuromuscular problems, GI problems, and this can be life-threatening. So our treatment for serotonin syndrome is to remove the cause. So we would stop that medication and use symptom management as we try to lower that serotonin level. Next, we have our anxiolytics. These are used to treat anxiety, alcohol withdrawal, and it can also reduce agitation. The most common form of anti-anxiety agent is our benzodiazepines. Benzodiazepines enhance our GABA response, and it typically is a very fast-acting medication. So we often use this as PRN medication for things like panic disorders and severe agitation. It's also used to help somebody safely withdraw from alcohol because it has a very similar chemical composition to alcohol. So when someone is withdrawing from alcohol, they can develop alcohol-related seizures and delirium, and they can die from that. So by providing them with a benzodiazepine at, it's a kind of like a sliding scale dose, so slowly weaning them off the alcohol by slowly weaning them through the benzodiazepine process, we can prevent those seizures and death. Long-term use of benzodiazepines is discouraged because they can be highly addictive. They do also typically sedate the patient quite a bit. So while our patients are taking this, they're going to be a high fall risk. And a patient can overdose on a benzodiazepine. So the antidote for that is romazicon. Non-benzo related anti-anxiety medications act to increase serotonin. These are slower acting, but they can still be quite effective in treating anxiety. And the main one that we see for that is Boost Bar. Then we have our sedatives and our hypnotics. These are also agents that we can use to kind of sedate our patients. We very rarely use these in the hospital anymore, but they can also be used to treat insomnia. The main medication that you may see would be Halcyon, and this enhances GABA. And it also has interactions with grapefruit juice. So if our patient is taking this medication, which like I said, you probably won't see patients taking it, but if they are, we would want to educate them not to eat grapefruit while on it. Other things that we can use for insomnia or sedation that is a non-benzodiazepine is Ambien and Lunesta. So considerations for our sedatives, hypnotics, and our anti-anxiety agents is that benzodiazepines also should be discontinued gradually over several weeks and not abruptly discontinued, because just as alcohol withdrawal, benzodiazepine withdrawal can be very severe. We would want to educate our patients that it can cause severe sedation even during the daytime, so they should not be driving, operating machinery while taking these medications. We would want to tell the patient not to increase or change their dose without talking to their physician or provider. And then we would also want to educate them on side effects that can occur and advise them against alcohol, especially if they're taking that benzodiazepine. Benzodiazepines and alcohol combined can cause things like respiratory depression and ultimately death. Then we have our treatment for ADHD and chronic fatigue. So the main one that we would see for this is our stimulants, and that helps stimulate the patient so that they can focus better, or it can prevent that fatigue. Typically, these medications are stimulants like Ritalin, Adderall, and Focalin are also addictive, so we would want to very closely monitor use of that. And it can very frequently be abused, especially in school-age children and college-age students. Stimulants do help limit hyperactivity and impulsivity, but it can cause weight loss as well because it suppresses the individual's appetite. So we would want to make sure that we're monitoring their nutrition if they are taking a stimulant. For patients that don't want to take stimulants but still need treatment for ADHD, we can provide them with Strattera. Strattera is more commonly used in a psychiatric facility because it does not have that addictive factor. We can also encourage some non-pharmacological methods for treating ADHD, and those are things that we can do that can help the patient focus or refocus their attention. And this could be things like chewing gum, standing while doing activities, learning refocusing techniques, having visual reminders of what they're supposed to be doing, like sticky notes around and things like that. We can also use non-psychiatric medications to treat either side effects of psychiatric disorders or symptoms of psychiatric disorders. So for example, the anticholinergics I've talked about quite a bit because it can be used with antipsychotics to prevent the EPS and NMS symptoms. If we are providing our patient with Benadryl, Cogentin, or other anticholinergics, we would want to make sure that we monitor them for sleepiness, dry mouth, and all those other anticholinergic effects. As far as cardiac medications go, we can use things like clonidine and propranolol to treat anxiety as well as tremors. So if our patient is taking this for anxiety or for that akathisia, we would want to make sure that we monitor their blood pressure and pulse. Then we have our street drugs or herbal medications. So these are vitamins and herbs that patients can use to treat different psychiatric symptoms as well. As I mentioned earlier, it's really important that we assess if our patient is taking any of these to treat their symptoms, because it can interfere with other medications and it can lead to very serious complications like serotonin syndrome. So St. John's wort is the one that we most often see, and it can be used to treat depression, pain, anxiety, insomnia, and PMS symptoms. And the way that it does this is it modulates serotonin, dopamine, and norepinephrine. So like I mentioned multiple times, it can increase the risk of serotonin syndrome. Kava can be used to treat anxiety because it inhibits noradrenaline reuptake. Valerian can be used to treat insomnia or nervousness. Multivitamins, thiamine, folic acid, those can all be used to treat fatigue, apathy, depression, and withdrawal symptoms, especially patients that are withdrawing from opioids. Melatonin can be used to treat sleep, and this is the one that we most commonly see prescribed in the hospital. And then DMAE can be used to treat jet lag, ADHD, Alzheimer's disorder, Huntington's chorea, and tardive dyskinesia. And DMAE can also improve memory. So just to reiterate some extra considerations when talking about medication management in our patients, compliance is a very, very, very huge issue. As I mentioned, it can be limited by hallucinations, side effects. A patient may start to feel good, so they may think they don't need the medications anymore. They may stop taking the medications because they're worried about stigma. So there are different things that we can do to improve compliance, starting with making sure that our treatment is patient-centered and that we're working with our patients and figuring out what's going to be best for them, not as only as far as the symptoms they're showing, but the lifestyles that they live. We can provide them with long-acting injections and, if need be, put them on a court order for treatment and have guardianship approval of medications. We definitely want to monitor for any side effects and therapeutic response. We may need to do lab monitoring, and we also want to monitor for any medication interactions. In addition to our medications, there are alternative therapies that we can also provide for our patients. This is things like electroconvulsive therapy, transmagnetic stimulation, phototherapy, and VNS therapy. Oops. Going back. So ECT, or electroconvulsive therapy, is a medically induced seizure. And during this time, we give the patient anesthesia and a muscle relaxant. We hyperoxygenate them and make sure that we're monitoring their oxygen level the whole time. And then we place electrodes on their head. It can either be in a unilateral or a bilateral positioning, depending on what part of the brain we want to target. Then we give them small electric pulsations to induce a seizure. Because they have that muscle relaxant, they're not going to have a full body seizure. They're just going to experience seizure activity in their brain. Initially, we're going to monitor them for things like a headache, muscle aches, orientation, and sedation. And overall, we're going to assess for improvement in symptoms. Typically, they'll receive this treatment 3 days a week for 12 weeks, and then they can receive maintenance ECT, where they get ECT about once a month. Transmagnetic stimulation, or TMS, is similar to ECT in the approach. However, we don't need to sedate the patient, we don't need to give them muscle relaxation, and we just put a magnetic pad on their brain and we send magnetic pulsations to the brain. They typically have this treatment for 1 hour for 30 days straight. So it is a little bit more time consuming than ECT, but they don't have as much of the effects from the anesthesia or the muscle relaxants. And it is more effective than taking antidepressants, but because it is more invasive than taking medications, we typically can't provide this therapy prior to them starting medications and trying to see if those are effective. Not a lot of insurances cover TMS yet, so while it is one of the better therapies out there, your patients may not have access to it. Phototherapy is used to treat seasonal affective disorder, and this is through using artificial light where the patient can sit under it anywhere from 30 minutes to 5 hours a day. And then we have vagus nerve stimulation, and this is an implant that's placed into the brain and gives magnetic pulses to the brain and works very similarly to TMS, except that it is permanently in the patient's brain. So that is it for our medication-based interventions in our treatments for psychiatric disorders. But another type of treatment that we can do is group therapy. So now we're going to talk about group interventions. So groups are often used to enhance self-understanding, conquer any unwanted thoughts and feelings, and learn new behaviors. The first part to forming a group is selecting our members, so deciding who needs to attend this therapy and whether or not they need to be referred into the group or if they can be self-selected, meaning that the patient can seek out the group themselves. Then we determined if it will be a closed or an open-ended group. So that means once the group starts, is it just those people that can attend for a certain amount of time, or can new people come and go each week? Then we look at the group size. A group of 2 people is called a dyad, 3 people is called a triad. Smaller groups are between 3 and 8 people, and these are usually a little bit more intimate and better for interactive groups. Or we can have a large group, which is greater than 8 people, and these are more often used for things like psychoeducation. Then we determine the group content. So what is the purpose of the group? And then you decide the leadership style. So a direct leadership is when a leader gives all the direction and information with limited discussion. So a direct leadership style is going to be more effective for things like your psychoeducation therapy or medication education. Indirect therapy is when the leader reflects as group members lead the discussion, and that's typically more beneficial for like self-help groups. And then you can have co-leadership, where the leader and the group members very much share the leadership and guidance of the discussions. And then lastly, we have to look for an appropriate group location. We want to make sure that we're providing a location that is quiet, pleasant, has adequate space, and adequate privacy. And that's a lot related to that milieu therapy. Once we've formed our group, we work on the stages of leading a group. So the different stages is we start off with the beginning stage or the honeymoon stage. At this point, the leader will acknowledge members of the group, and you set the working environment. So you establish the purpose and expectations and rules of the group. Everyone establishes rapport with each other. And during this time, members may try and test the trust and cohesiveness of the group. So at this point, you're at your forming stage. Everyone's in agreement, they're kind of deciding the purpose, and they're looking for guidance and direction. Then we enter the working stage of the group, and this is where people are sharing ideas and developing relationships. The group personality, norms, rules, and standards develop, and the leader can help facilitate verbal and nonverbal communication that encourages interaction. So the individuals attending the groups are going to build their communication pathways. They're going to identify group members that they like. They're maybe forming subgroups at this time. There may be some members that are maybe more isolated, that as a leader, you want to try and maximize their interaction with others. At this point, we may experiencing that storming where conflict occurs as people are looking for increased clarity or purpose. They may be engaging in power struggles. At this time, we're also going to be looking for group member roles, and these may be formally assigned. So you may say, hey, you're going to be the recorder for this meeting, and they're going to record the notes, or you're going to be the coordinator or the timekeeper and make sure that we're keeping on schedule. Or they may be more informal, like the harmonizer, someone that is always trying and keep the peace, the compromiser that naturally just tries to facilitate effective communications. You may also have some challenging behaviors this time, like someone that monopolizes the conversation, argumentative members, members that dislike each other, the silent members. So as a group leader, it's really important that you are able to observe all these different things, but also know how to minimize and maximize certain behaviors so that everyone can gain meaning from the group and find purpose with it. And this is going to be the whole process of moving into the norming and performing. So with norming, people have moved past that conflict that we see in the storming. They're in more agreement and consensus. The roles and responsibilities are clear. So once the norming has occurred, we can actually begin performing and focusing on the purpose of the group, focusing on goal achievement, delegation. Everyone has that clear vision and purpose. And then we enter the resolution or the termination stage. At this point, you're in the adjourning process and your tasks are completed. People are feeling good about the achievement. They recognize the growth that they've made, but they may also start to fear that they're losing contact and belonging with each other. So some individuals may try and bring back up working stage issues. So as a group leader, it's important to avoid those working stage issues and to discuss and summarize all the work and accomplishments of the group. There are different types of group that a nurse may lead. Psychoeducation helps patients to learn about all things related to psychiatric treatments and illness. Task groups are given a common goal to accomplish. So, for example, if someone donates a bunch of money to a unit but says that the patients must decide what that money might be used for, you might form a task group that everyone's purpose is to come together and decide what that money is going to be used for. You can have decision-making groups, supportive therapy like AA, psychotherapy like art therapy, theater therapy, or play therapy. Art therapy is when you use different art techniques to help express your emotions or your subconscious. Theater therapy is where you act out your different emotions, and it's used pretty frequently with people that have experienced trauma. And then play therapy is often used with children, and it's when you play dolls or Legos or whatever you're playing with the patient. The issues that their toys bring up kind of gives you insight into what's going on with them. Then you can have your self-help groups, and these are things like improving nutrition, social skills, communication. It can be exercise related. You can have age-related groups or family-based groups. You can also have groups that are based on medication education, symptom management, self-care, that reminiscence therapy that I talked about earlier, goal setting groups, and anger management. And while nurses can lead all of these groups, the groups may also be led by social workers, psychiatrists, and others. So that is a brief overview of all the different interventions and ways to apply the nursing process in psychiatric nursing.